So dito sa talk ko, I will really just focus on what will happen the next time that you see the patient, no? And the idea is nakasimula na siya ng gamot. Okay? So like earlier, we're going to start with a take-off case. Kanina, si CR, dumating sa clinic, basically feeling okay, very anxious to start treatment, no? So he is back at clinic today after seeing you 1 month ago, no? Nabigyan na siya ng gamot. Ang sinart sa kanya is LTE. So if you're not familiar with the term LTE or lamivudine tenofovir efavirenz, you will learn about that later on. LTE is a 3-in-1. So yun yung binigay sa kanya. And now he says generally he feels better. Tumataba na nga daw siya, no? However, he says that he still gets dizzy after taking his pill and says that he seems to be more depressed these days, no? Parang may effect yata yung gamot sa kanya. So let's use this case as a take-off, and this is just to remind you yung continuum of care, no? So na-diagnose na natin si CR, tapos pasyente na natin siya sa treatment hub, na-start na natin siya ng gamot. So we need to make sure that he is retained in care. And then eventually we will learn later on, no? Now we need to check the viral load to achieve or to document viral suppression. So what are the components of the follow-up visit? So you need to take an interval history, a physical examination. You need to check on some health maintenance things or health maintenance stuff, no? And then some next steps to think about. Ano yung susunod na gagawin for the subsequent follow-ups. So, interval history. So, kumustahan yan basically. And you need to build on the rapport that you established from the previous visit. Okay? Dapat by now, medyo familiar ka na with his background, no? Kilala mo na siguro yung family members, alam mo na kung sino yung mga may alam about his illness. You're continuing to encourage him to disclose the diagnosis to at least the closest, most trusted loved ones, no? It's a good idea to encourage them to do that. And then you ask, ano na nangyari? Kamusta ka na? How have you been since our last meeting, no? Meron bang mga symptoms na na feel ka, nagkasakit ka ba, etc. Usually what I do with my patients is after the visit where I give them, kasi sa Medical City, para ma-startan sila ng treatment hub namin ng gamot, kailangan ng certificate from the doctor that says they're ready to start, ang tawag endorsement letter, no? So I give them the endorsement letter and then they schedule a visit with iReact, with the treatment hub. You might have a different system in your treatment hubs or your clinics, no? Pero yun yung sistema sa amin. So they eventually start their medications and then I tell them, set an appointment with me 1 month after you start your antiretrovirals. And for that visit, I only really just sit with them and ask how they're doing. Wala pang blood tests yun, no? Because I want to see that they're taking their medications well, whether they're having problems with side effects, etc. Okay, so you will learn best what's going on with your patient by again doing a comprehensive review of systems. Okay, so the easiest way to remember how to do a review of systems is to go head to toe. Okay, so headache, vision problems, hearing problems, ubo, sipon, no? So oral thrush, difficulty swallowing, and then you go down the line: chest, abdomen, and then extremities. Okay, so you look for any new symptoms, whether na hospital siya. Are there any red flags that require escalation of care? No, for example, patient has a low CD4 count, tapos bigla siya nag-blurring of vision, no? Baka meron siyang CMV, or hingal siya ngayon, baka nagpi-PCP siya. So these are the things that eventually you will learn about yung opportunistic infections, or you're giving cotrimoxazole, tapos nag-Steven Johnson siya. So yun yung mga kailangan yung hanapin na red flags. so that you can send to the appropriate clinic or hospital. Okay? Mapipick up nyo yan when you do a complete and comprehensive review of systems. The next is to do a comprehensive medication review. Doon sa 1 pill a day na iniinom niyang gamot for HIV, 3 gamot na yon agad, no? Lamivudine, efavirenz, tenofovir. Kung medyo matanda yung pasyente ninyo, meron niyang gamot for high blood, meron niyang gamot for diabetes, etc. So, very, very prone sila to drug-to-drug interactions. And you always need to do a good medication review. Kung kakadiagnose lang nila at mababa ang CD4 count, then they are on some prophylactic medications, cotrimoxazole, IPT, yung isoniazid prevention therapy. No, so you need to ask them to list it down kung ano yung mga iniinom nila. Ako, I make it a point to ask, anong oras mo iniinom tong gamot na to? Ilang tableta iniinom mo? Tapos, meron ka bang nami-miss? No? For example, ang TB medications, ang proper na pag-inom ng TB medicines, dapat yan, sabihin natin, normal weight yung pasyente, mga 70 kilograms. So, dapat yan, mga 4 tablets of TB medications, lahat sa umaga, 30 minutes before breakfast. No? May mga pasyente na dadating sa'yo, oh, Doc, iniinom ko po yung aking TB medications. No? Tatanungin mo, paano mo iniinom? Iniinom ko po isa sa umaga, isa sa tanghali, isa sa gabi. So, mali yung pag-inom niya. And by doing a comprehensive medicine review, you're able to educate your patient and correct yung mga mali na possibly ginagawa nila with their medicines. No? Also very important, interval sexual activity and safe sexual practices. No? Lalo na kung hindi pa sila virologically suppressed, then you need to be emphasizing that if they're going to engage in sexual activity, they need to be responsible and practice safe sexual intercourse. Review any laboratory tests that the patient has brought in. So like I said kanina, yung after the initial visit, so sasabihin ko sa kanila, come back to see me 1 month after starting the medications, magkumustahan tayo. And then 2 months later, meron na yan blood tests. No? Pinapastart ko na silang mag-monitoring labs. Tapos yun, for the first year, parang every 3 months silang merong repeat blood tests. So, alam na nila yon. Pagdating nila sa kliniko, dala na nila yung results ng blood tests para ma-review na namin. No? And then we can intervene kung meron mang makitang problema doon sa blood tests. If your patient is already on ART, you need to check adherence also. No? One way to screen is, you're not judgmental, but say, ilan nang hindi mo na inom this month or this week, no? Or in a week, ilang beses kang nakakamiss. In that way, you're able to gauge if diligent yung pasyente or at risk siya for developing resistance. Kasi kung if he or she misses 2 or 3 pills in a week, no, ilang beses yun na nami-miss in a month. So baka hindi kayo maka-achieve ng virologic suppression that way. You also need to ask about symptoms that are temporally related to medications. For example, Doc, pag iniinom ko yung gamot ko, nahihilo ako, no? So tinutulog ko na lang. Or pag iniinom ko yung gamot ko, sumasakit ang tiyan ko. Palagi yun, no? So you need to figure out what's going on. And give appropriate medication. Sabihin natin, nag-hyperacidity yung pasyente, bigyan ng antacid or something like that. No? If you find that your patient is non-adherent or is poorly adherent, you need to look out for the root causes. No? And in this situation, you try to be non-judgmental kahit gustong-gusto mo nang pagalitan yung pasyente for not taking his medications. Bakit? Kasi minsan, tinitigil nila yung gamot nila kasi hilong-hilo sila because of efavirenz, no? or nalalakihan sila dun sa tableta, or nasusuka sila. Or sabihin natin, this is very very common in mga BPOs, no, yung mga nagtatrabaho sa call centers, and yung work schedule nila very erratic, no, so they tend to miss their medications. Or baka they're just not ready yet to start ART, no? So you need to look for the exact cause bakit hindi sila nakakainom, and then you address that para hindi ka lang pagalit ng pagalit sa pasyente and say, you need to take your medication. You need to find solutions for them so that it will work, no? Para they will find it easier to take their medications. After the interval history, you do a physical examination. Usually kapag mga repeat visits na, I don't do a thorough an exam anymore, but you do need to sort of graze through the major body areas, no? So syempre nandiyan ang vital signs, and you need to include weight. Kasi especially if a patient starts with very low CD4 counts and they're very sick, no? Once they start on the ART and they start feeling better, kakain na yan ng marami, no? And they tend to gain weight and some of them will become obese, which will be problematic later on, because our patients with HIV, they tend to develop more cardiac disease later in life, no? So kailangan early on pa lang, you need to tell your patients na they need to watch their weight and their diet. Head and neck, so vital signs including weight, head and neck, so pinapabuka ko lang bibig nila to check for thrush. Kung may kulane, tinitignan ko lang kung mas lumiit na. I do an auscultation, so heart and lungs. Abdomen, cursory exam lang kung merong any areas of tenderness, for example. Any new skin lesions or edema. Tapos, later on, pag very stable na yung pasyente, no, talagang halos very focused na lang yung physical exam on something that they may be complaining about, no? And then we go to health maintenance. Remember that at least for the doctors and the healthcare workers who directly see and take care of patients, most HIV patients will see you as their primary care provider, no? So you need to be looking at immunizations, for example. As part of your clinic, dapat alam mo kung ano yung kailangan na immunizations for your patients, no? And you need to try and get them up to date. In my clinic, I give the vaccines to my patients, no? So there has to be some vaccine program that you can plug them into kung wala yung clinic ninyo. You need to know your smoking status, your patient's smoking status, para you can advise them on smoking cessation. Pap smears for women, annual pap smears. And then kung above 50, colonoscopy, yung mga ganon na kailangan chine-check natin routinely, no? That's part of providing primary care to our patients. For the doctors, especially the internists, dapat alam natin yon. Okay, I think Doc Kate, they will have a session on immunizations. So this is just like a rundown of the vaccines that they need. No, hepatitis A and B, herpes zoster if they are above a certain age, 50 years old, and if hindi na sila immunocompromised masyado, it's any live virus vaccine is contraindicated if the CD4 is less than 200. So herpes zoster, you at least yung available dito yung Zostavax, hindi yun pwede kasi live virus vaccine yun. HPV is recommended until the age of 26, optional until the age of 45, no? Influenza, dapat yearly sila nagpapabakuna. MMR, live virus yan, again, contraindicated in CD4 less than 200. Meningococcal in some patients. This is a US-based paper, so some of them we don't routinely give to our patients. Ako, I routinely give pneumococcal vaccines to my patients. Tdap as well, every 10 years. No? Tapos varicella. So, yung in this list, yung 3 na hindi mo pwedeng ibigay in a patient with a low CD4 count are herpes zoster, MMR, and varicella. I think I included that as a pre-test question. Okay. And then, follow-up labs. No? Ito yung dapat dala nila. Dapat dala nila when they come to see me for follow-up. If the CD4 count is below 200, then I ask them to repeat it until the CD4 rises above 200, and then I stop. I know I'm aware that some treatment hubs have stopped monitoring CD4 count. Pero ako, in my practice, I still check the CD4 until umakit siya ng 200 and then I stop. Viral load, may mga pasyente ako na gusto nila every 6 months sila mag-viral load, marami silang pera, fine. Pero at the very least, you should be checking annually, no? And as part of the PhilHealth or OHAT package, they should get annual free viral loads through the treatment hubs, no? So may mga pasyente who are not able to shoulder the cost of a viral load. Then they just wait for the OHAT to be approved, their benefit to be approved, and the hub facilitates the viral load for them. In my practice, ang standard na ginagawa ko is I offer the viral load 3 months or 6 months after they've started antiretroviral therapy, no? Kung kaya naman nila i-shoulder, walang problema sa kanila, then they get the viral load either at 3 or 6 months after they start the ART. CBC, every visit yan, every 3 to 4 months, no? Especially when they're on zidovudine, kasi nakaka-cause ng anemia ang zidovudine. You need to check chemistries, no? Ako, I routinely check creatinine and SGPT. If the patient is on cotrimoxazole, I check serum potassium every 3 to 6 months. I do a lipid profile annually, especially for those on protease inhibitors, yung lopinavir, ritonavir. Urinalysis as a way to screen for kidney problems, usually and annually, lalo na yung mga nakatenofovir, disoproxil, fumarate. FBS and A1C, especially if meron silang risk factors, no, family history, they're obese or whatnot. And then, of course, STI. Hi, Amy Joy. STI screening based on risk. So, and that's why you need to ask about sexual activity. No, you can decide to do to just screen them for, say, syphilis if nagdududa ka sa history nila. But if you find that your patient is reliable, then pag sinabi niya, I had unprotected intercourse, etc., then you check STIs. Okay. I want to emphasize this, and I'm sure this will be covered in another talk, no? But the importance of the viral load is to check if naging undetectable na sila. And I think we need to emphasize and celebrate when they become undetectable, because I'm sure by now you've heard about U is equal to U. Undetectable is equal to untransmittable. Ibig sabihin, they cease to become contagious, no? Kapag ang viral load nila is already undetectable. Okay? And I think we need to celebrate that with them kasi that's a milestone in their treatment, no? And if you hype it up with them, syempre mas maengganyo sila to continue taking their medications regularly, to do the viral loads more regularly, and to show it to you, etc. No? Yung U is to you, lalo na yung mga couples, no? Yung serodiscordant couples, they really look forward to the time na undetectable na sila, because it means so much, no? There's so much implication for someone to become undetectable. So what are the next steps? So, natapos mo na history, physical examination, na-review mo na yung laboratory tests, na-examine. So ano na yung next? No? So, you need to think about when the next visit is. Ako, usually in the first year, I ask them to follow up every 3 months. Kung wala masyadong problema, stable, then I see them every 3 months, and every 3 months, may dala silang laboratory tests. Yung blood work na pinapagawa ko prior to the next visit, the request I already give to them at the time na nagkita kami. Usually, that's just CBC, creatinine, and SGPT. If less than 200 ang kanilang CD4 count, I ask them to repeat. And then, like I said, if the patient is able, I ask them to do a viral load at the 3-month or the 6-month mark. Kapag undetectable na yon, then I check in a year. You also need to assess whether you can already discontinue some of the prophylactic medications, no? Like cotrimoxazole, for example. If your patient still needs it, make sure to ask whether kailangan ng bagong prescription. Remember, these are antibiotics, no? So dapat may prescription ng doktor. Otherwise, pag hindi ka nagbigay, your patient will try and game the system, no? Either gagamit siya ng lumang prescription or whatnot. So para hindi na magka-problema yung pasyente mo, make sure that your prescriptions are always up to date. And then, you always end the visit by inviting your patient to ask questions. It's always important kasi one of the ways, no, to destroy the rapport is for your patient to leave the clinic na hindi na address yung lahat ng concerns niya. So you always ask, do you understand? Are there any questions? No, how can I address any of your concerns?